Thank you, Deval.
Yeah, we move on to the next paper, asymptomatic enlarged prostate. Mohsin.
Good morning, respected chairpersons. Good morning, dear delegates. Myself, Dr. Mohsin. I'm from Assistant Professor in Guntur Medical College. So the topic is given to me is asymptomatic enlarged prostate. Most of us have encountered these in our OPDs regularly. So I'm discussing a few of the case scenarios which I have encountered 3 years ago when I was in corporate as a consultant. So here is a subject, a gentleman, Mr. A, who is a 45-year-old male. He's a senior executive in oil company. He, as per his company policy, he underwent an annual health checkup. In that, 60-gram prostate was an ultrasound, and he was referred by a general practitioner to me. And he was on taking history, was asymptomatic with IPSS was 0. On clinical examination on DRE, it's a grade 2 and benign field. When I did a Euroflow, it's a good flow with the 26, Qmax is 26 and average flow is 16. With he's voiding within less than a minute and 420 ml is emptying. And residual is also at 20 ml, is less to the complete, and CU and RFT are normal. Coming to my second gentleman, who is a 58-year-old, he's a hotel manager. He presented to a general surgeon with a mild upper abdominal pain. So on ultrasound, there was a cholelithiasis, but incidentally a prostate of 80 grams, and the general surgeon referred to me. On taking history, he had occasional nocturia, not a regular one, two times occasionally, and his IPSS was like 3. And distal rectal examination is again grade 2 prostate with a benign field. His Euroflow also is good with minimal residual, and CU and RFT are normal. And the third gentleman, who is a general physician, he is a 64-year-old gentleman, and he wants to travel. In front of his foreign travel, he did just a master health checkup. In that, the ultrasound was the 110 cc was his ultrasound prostate. And he was referred to me, and again he has absolutely no symptoms. Occasionally he has some nocturia, and again his IPSS is 2. His grading of the prostate is grade 2 benign field, and his Euroflow is also almost good with the 16 is Qmax and average flow is 12, but residual is less. So I faced this head scratching scenario whether to treat this gentleman or not. And most of the, as I said, most of the incidental detections, like during health checkups, master health checkups, and for any other problems in ultrasound detection, and in some cross-sectional imaging like CT and MRI, these glands are getting detected. No, going in, as we detect mostly in ultrasound, going to a radiological classification, a normal prostate is 15 to 20 grams. Which is a small prostate is considered to 20 to 40 grams, and 40 to 80 is a medium-sized prostate gland, and more than 80 grams is considered to be a large prostate gland as per this classification. And most of the prostates might be symptomatic, and sometimes they might be asymptomatic also. That's the idea of this talk. And most of the patients who come to us OPD, maybe they are having a big prostate, but they are not aware of the symptoms as well. They present bit late. So how do, as we all aware, we evaluate, like we do a self-assessment by giving IPSS chart, which is in the native language as well in English, and we do a DRE, a complete urine examination, renal function test, post PVR check, and uroflowmetry, and serum PSA is after only shared decision making with the patient. As we all aware, let's classify in 3 types: storage, voiding, and post micturition symptoms. And this IPSS symptom score is very essential in initial evaluation of such individuals, as well as in a follow-up after treatment or without treatment on follow-up. So men with large prostates will have, of course, we have a present with LUTs, and they sometimes with acute or chronic retention. This Wetton FIS cohort study showed men with more than 30 grams are prone to be AUR, 3 times more prone to AUR. And this Olmsted County study showed that men with prostate more than 50 cc are 3.5 times more prone for a moderate to severe LUTs. So this historic paper we all aware, it's published in 1993 in Journal of Urology. So the study was done by Barry and colleagues. So this paper shows the relationship of prostatic symptoms with anatomical and physiological considerations. And in this, they showed little correlation between prostate volume and severity of LUTs, because the majority of the gland, which is around the periurethral region, that chokes, not the whole size of the prostate. And the similar thing was explained in this paper as well. This is also a historic paper that is a natural history of the prostate as done by German and colleagues, which is published in Journal of Urology in 1995. In this also, there was a little correlation between LUTs and the size of the prostate. And this Olmsted County study shows that there are more than 3 times more men are more risk if prostate size is more than 50 grams. This is one of the thing. And based on this basis, we try to treat and shrink the prostate. If he is symptomatic, based on this basis, more than 50 grams, we try to shrink the prostate and to reduce the LUTs and improve the IPSS score. And this is another significant paper published in New England Journal of Medicine in 1992. This is a famous finasteride study done by Gormley. It's by 895 subjects. It's a randomized controlled trial comparing the finasteride 1 mg, 5 mg, and with the placebo. So in this study, at the end of the study, the prostate gland is 19% reduction in the 5 mg and 18% in 1 mg and placebo. It is 3%. That means a significant reduction, like almost 5 mg, 1 mg is the same reduction in the volume is 19-18%. But finasteride 5 mg is has improvement in LUTs over a period of 1 year compared to 1 mg. And there's another paper in New England Journal of Medicine is published in 1998. This is a famous study that there is a long-term efficacy safety study that is called PROSCAR study. This here 3,000 subjects has been tested. It is also a randomized control study, finasteride or placebo for a period of 1 year. In this, while using the finasteride there is an improvement in the flow rate as well as there is a finasteride reduce the risk of needing for surgery and development of AUR for this percentage. And going for this EAU guide, this flow chart, the algorithm management of LUTs, the subject who is here with no symptoms at all straight away goes to watchful waiting category. If at all, if he's having a large prostate, there he fits into a, because he's not having any symptoms, he fits into a education and lifestyle modifications. Coming to AU guidelines, what AU guidelines says is, so offer men with mild or moderate symptoms which are minimally bothered with only the watchful waiting. That is a strong recommendation. And similarly, LUTs, men with minimal LUTs, lifestyle modification should be advised if you want to start, even if you want to start a medical management or prior to it, you need to give a lifestyle modification is a strong recommendation. And alpha blockers are reserved for men with moderate to severe LUTs, which are bothersome. And if gland size is more than 40 ml, then 5-alpha reductase can be combined. And we need to counsel the patients about the slow onset of 5-alpha reductase inhibitor, which is also a strong recommendation. Coming to American Urology guidelines, here it's almost the same. So the clinician, based on the for minimal non-bothersome LUTs, lifestyle modification, and for moderate to severe LUTs, alpha blocker should be started. And now what can be done in these subjects, what I have discussed. So main thing is education. We need to really educate them. So what's the prostate, how it grows along with the age. It's just like hair will gray or bones will weak as we grow. Similarly, in that fashion, we need to educate them. We need to reassure them really that it doesn't cause anything to you. We need to have a proper follow-up. And we need to, if they are having a little bit LUTs, or we can advise the proper lifestyle modifications, bladder training, everything. And we need to make him understand that he need to come for a periodic monitoring, periodic checkup regularly. So how I follow is like after 6 months or 1 year with IPSS score again for monitoring, and Euroflow to document proper flow, how the flow with the last time, and residual urine, and to complete with complete urine examination and renal function tests. My take home message here is medical management is only for bothersome LUTs. So, and treat the LUTs, not the size of the prostate. If there are no LUTs, no need of tablets. Size alone doesn't matter, and just wait and watch. And he's not a patient, he's our guest. Ask the guest to visit again to the clinic. And at the end of my session, the patient, I'm sorry, it's not patient, he's our guest. He knows that he's not having any symptoms. His prostate is enlarged, so he will come back again for follow-up. Thank you once and all. Thank Abhishek sir and UU Council for giving me this opportunity. Thank you for the patient listening.
Mohsin, you rightly said a patient, we don't treat the size, we treat the symptoms. Since he is symptomatic, we're not treating, reassuring him. So in a patient, like you mentioned, the third patient, 64-year-old medical going abroad.
Yeah.
So what lifestyle advice would you advise him? This is for wider dissemination. What lifestyle advice would you advise him, especially on his travel abroad?
So actually, he is not having any symptoms. So he has occasional nocturia sometimes. So I asked him to fluid restriction after say 8 p.m. or 8:30 based on his fluid intake, and I hear what is his fluid intake per day, and I asked him to regulate the fluid intake, and I'll advise him to do a timed voiding every 3 hourly. Timed voiding, and I ask him to do a double voiding. Whenever he goes for a void, wait for a 10 seconds. He is having very minimal, like 20 ml. Even to ensure him, we can tell that will be good to maintain his bladder health over a long period.